Hey, welcome to my podcast. My name is Dr. Brendan McCarthy. I'm the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Thank you so much for tuning in. I'm glad to be here. We are today continuing on a series that we've been making about PCOS, polycystic ovarian syndrome. This is the last one in this series for now. We may do some more in the future on PCOS. It is an incredibly complex and important topic to go over with women. As more research comes out, or if there's more questions from you on your end, we're going to make another episode because that's why we're here. I'm here for that purpose. I love doing this work, and your comments help drive this podcast, your input. I really do regard what you say, what you read. Justin and I spend time reading your comments throughout Instagram and on YouTube. And I just really appreciate it. I really always appreciate you guys' input. So before we get into today's episode, please do me a favor and scroll down. If you're on YouTube, there's a little button down there that tells you how to subscribe. It's subscribe, and then we'll get started. Was it too bumpy?
No, that was good.
All right.
I like it.
I have handouts for you, and I'm going to point out what each handout is, and I'm going to stop, and I'm going to put the handout, and I'm going to send you the handout. This is handout 1. This is handout 2. Okay. Today, I want to drill down a little bit more into the treatment of PCOS that I've done in practice. We've already gone over a lot of diet. We've gone over a lot of the different protocols associated with it that I've used and a lot of the biochemistry involved in polycystic ovarian syndrome. I want to go into specifically today progesterone, and we're going to talk about androgens as well and how to bring those androgens back down a little bit and what to look for in the androgens. Androgens being like testosterone, dihydrotestosterone, DHEA, androstenedione, androstenediol. Again, I'll get into more of it later. But this is to help talk about the different therapies we use, like progesterone in this sense, and then how we're going to help really manage that androgen level and bring that down, and then how we move forward with these patients. Let's go back to remembering what causes polycystic ovarian syndrome, or what we suspect causes it. We know for sure that elevated insulin is a primary driver of this. We know this, and we know that that's most likely the primary cause as well. The misunderstanding or lack of knowledge is more like, where do we have this insulin excess coming from? Why is this happening? Normally, diet drives insulin. And so if a person's eating a high carbohydrate-based diet, they're going to have high glucose, and that high glucose is going to cause high insulin. There's a problem with that philosophy because there's a lot of people who don't have a great diet that have high glucose, that have high insulin, and they don't have polycystic ovarian syndrome. There's more to it than that. So when people say just cut calories, that's where I get frustrated. Yes, it's important to control diet. Yes, it's important to address the causes of diet in there that may be affecting the insulin. We've talked about that. But still, we want to dive deeper and understand this deeper. And as I mentioned in the previous episode, when you are looking at this, you can consider this as being more of an injury that's happened to the insulin receptor. And since the insulin receptor is damaged, it's going to cause the body to want to generate more insulin to help overcome that injury, so to speak. And that elevated level of insulin, that from the damaged insulin receptor leads to that elevated insulin that goes to pituitary and affects the way the pituitary releases certain messages that go to the ovaries. And that is luteinizing hormone. Now, luteinizing hormone is going to be very, very high in these situations because that's what insulin will do. It'll trigger this feedback loop, causing more luteinizing hormone to be secreted. That elevated luteinizing hormone, when it's super physiological, just out of range or out of ratio, you're going to see that stimulating the body to make more androgens. And that's something that you would think of as being, that's the testosterone, DHEA, androstenedione, et cetera, dihydro and free testosterone levels being elevated. That's what causes women to have hirsutism, which is a lot more body hair. Increased output of sebum on the skin. So you're going to have, acne breaking out. You're going to see just a lot of the things androgen affecting in the woman's body. And that's going to be coming from that elevated LH. Now, this is where a regular prescribing physician steps in and prescribes oral contraceptives. Oral contraceptives, by providing your body with another hormone, ends up trying to suppress your pituitary's output of that LH signal. So that's what the goal is with birth control, to suppress that. And there's good and bad to that. I'm not an advocate for it long-term, and if that's what we need to do short-term to stabilize a patient, I don't see that as a problem, but it's not a good long-term solution. What I use in practice more frequently is going to be oral micronized progesterone. Now let's go back to thinking about how a cycle moves through you and how your body moves through a cycle, so to speak, When you're having a normal cycle, the first half of the cycle, the follicular phase is going to be when your body is going to be secreting more estrogen. And that's because your ovaries have these follicles that have been recruited in the beginning of the cycle and secreting more estrogen. What caused that recruiting of follicles is follicle stimulating hormone that came from the pituitary, and that stimulates that first stage. Then you're going to hit a crescendo of estrogen. Estrogen is going to live a high level right around day 12, around you should ovulate. Estrogen is hitting this crescendo. That stimulates the pituitary to release luteinizing hormone. Then luteinizing hormone is being secreted, and the goal of luteinizing hormone is to bring up progesterone. So when you give a woman progesterone, what it does normally, biologically, it should suppress luteinizing hormone. It should reduce luteinizing hormone. Now in polycystic ovarian syndrome, it does. It does. There's a studies, I'm going to cite one now, if you wouldn't mind. This is a great study to look at, and this is the Journal of Clinical Endocrinological Metabolism published this one. What they found was that when you gave a woman micronized progesterone, it had this impact by lowering luteinizing hormone. If you have the time to look this up, you'll see there are other studies that show it doesn't. You get a mixed bag with this. Part of that is because they haven't done a lot of research into women. They just haven't. Another part of it is because when you're giving them just progesterone, you're only going after part of the equation. This is why I spoke about insulin a minute ago. If I just give a woman polycystic ovarian syndrome, just give her progesterone, I'm going to be suppressing the pituitary from secreting luteinizing hormone only to the degree that it can do that in the face of elevated insulin. So if a patient presents to clinic and I'm treating her for polycystic ovarian syndrome, I need to have in my mind that insulin also needs to come down. So progesterone will help lower luteinizing hormone so long as you're getting that insulin down. And that's going to be through diet and through the several things we mentioned in the previous episode. That's why you want to go after luteinizing hormone with insulin also. So if you approach the patient with progesterone on one hand, luteinizing hormone on the other, you should see that progesterone on one hand and insulin reducing protocols on the other, you should see a reduction in luteinizing hormone in that patient. This is super complex. I know. I spent a lot of time thinking about you and thinking about this. It's so important to be able to communicate this with you in a reasonable way that makes sense, that's not buried in jargon and not so complicated that you can't hold on to it. And this is one of those things I always repeat myself because this is true. You know how to drive home. Let's put it this way. You know how to get home. If I were to put you in a different part of your town, you know how to get home. You know the pathways, you know the roads, you know where to turn, you know which best road to go down. Sometimes a day, this is going to have more traffic in this other area here. And over here, if you want to go by there, there's a place you want to stop and get lunch. You know your way around your neighborhood. And it took you time to know your way around your neighborhood. It's like that with biochemistry. It's just like learning streets and houses and where people live and where you get the things you need to get. It's very similar. I know a lot of biochemists would scream right now if they heard me saying that, but yeah, this is true. At the end of the day, it's about memorizing and understanding pathways, and not just memorizing, but really understanding them, internalizing it, and having it make sense to you. And for those of you with PCOS, I challenge you, not in a bad way, but I challenge you in a heartfelt way to take that time to onboard this information in a way that you understand it. Why you need to do that, in my opinion, is because there's so few resources out there for you that you can rely on. The more time you spend onboarding this information into your mind and creating a depth of understanding with it, the easier it'll be for you to navigate through this, because you don't have a lot of guidance out there that you can rely on. So, back to the biochemistry. Lowering the luteinizing hormone is important role of progesterone, and I use it in clinic. I use lab work to verify I'm on the right place. I use lab work to verify insulin is moving down. I want your insulin to be close to 4 on a fasting morning panel, and I want progesterone to be somewhere around 10 to even 20 if I can get it there with a patient with polycystic ovarian syndrome, and that's during the luteal phase. Day 18 to day 28, I'm going to be pushing during those 10 days to have that progesterone up in that area on the labs. And I want the follicle stimulating hormone somewhere below 12, below 10, lower is better, but you're all unique. So it's not like, well, if I didn't get it down to 6, I'm a failure. If I didn't get down to, no, I do my best. We do our best. We don't set hard rules to this because that's not how the body works. And if I try and force it with more progesterone, keep slamming progesterone, that might not be the total solution with the patient. So it's important to use these guides that I'm giving you, these lab values, and put it in perspective of the case in front of you always, and do your best to move them in the right direction. And if it gets stuck, try and look around the case, see what else is around there that you may be needing to move in their diet and their lifestyle. So getting the progesterone to stop luteinizing hormone is very important. Another thing about progesterone. So through its ability to inhibit luteinizing hormone along with insulin control, you will see those androgens move down. That's your testosterone free and total. You'll see those go down. You'll also see sex hormone binding globulin start to move up. Now, sex hormone binding globulin, that's a thing that binds to your testosterone and renders it inert. In polycystic ovarian syndrome, that sex hormone binding globulin is very low. So any testosterone your body is making, it's going to be immediately available. There's no buffer to it. There's no way to slow it down. You just make it and it's just everywhere. And that's what causes that hirsutism that you see. And so when we want to lower the insulin and we lower luteinizing hormone, that's a two-prong approach that's going to help improve that androgen level. Progesterone helps lower the luteinizing hormone. Diet, lifestyle, and some of the supplements I talked about will help lower that insulin. And that's how you're going to get that sex hormone binding globulin to a better place. And so you use your labs to verify that. What else does progesterone do in here? What else? And you see, I'm talking about progesterone, but I'm always throwing around, got to watch that insulin because you can't do a standalone. Women are not a one button operated machine. It's so much more complex. It's balancing and it's harmony. And this is where medicine is an art. And the woman in front of you is a unique person who needs unique thinking, unique processing on your end to understand them. Speaking to physicians and care providers. Progesterone lowers cholesterol, which is great because that's another common things we see with women with polycystic ovarian syndrome. The thing I want to let you know about this is important. Those studies that show this, that study I just talked about in the Journal of Clinical Endocrinological Metabolism, JCEM, they talk about how transvaginal progesterone does not have this benefit. Now, transvaginal progesterone, many of you use, it does have some benefit, but it does not always move these numbers. So that's only oral micronized progesterone that we know that I recommend to do that. If you're only using transvaginal and that's helping with symptoms and you cannot get a prescription for oral micronized progesterone, fine, do the transvaginal, get the best results you can get. But I would hope that we do our best to get a doctor on board that will prescribe a version of progesterone that will work for you and move the labs in a direction. Transvaginal progesterone, if it helps with symptoms and symptom relief, I'm in with you. But again, I just want the best results. So please know that we know that transvaginal is not as effective or has been shown not to be effective in the case of polycystic ovarian syndrome when it comes to lowering luteinizing hormone, when it comes to lowering androgens, and when it comes to lowering cholesterol. What else does progesterone do? Why do I love it so much? So these women with polycystic ovarian syndrome have estrogen dominance by nature because they're not ovulating. So they're going to have their estrogen levels are going to be either supraphysiological or it's just high all the time, or it's going to be normal levels all the time, but there's no progesterone to balance it. So again, going back to a normal cycle, in the very beginning of the cycle, estrogen is dominant. It stimulates all those parts of you associated with fertility, the breasts, ovaries, cervix, uterus, adipose, bones. It does good things too, but it needs to be balanced with progesterone. If you don't have progesterone, that breast tissue, you see more fibrocystic changes. If it's binding to the lining of the uterus without progesterone, you're going to see endometrial hyperplasia, in the thickening of the lining of the uterus. You're going to see changes. That's what's going to cause you to have those follicles, irregularities with the follicles, which is polycystic ovarian syndrome. It's a cystic component. You're going to see that estrogen stimulating adipocytes, and you're going to see that weight gain associated with it because that's one of the impacts as well. So progesterone is key to reversing that excess damage excess estrogen damage to the body and bringing the benefit of estrogen to be present without it being excessive. So you're kind of harmonizing. So progesterone is a key player, very, very important. When we prescribe progesterone, I do oral micronized progesterone. I use it as a troche, which is a sublingual version of it. And that's one that dissolves. You let it dissolve before bed, and that helps with sleep. And we do 200. Sometimes I'll even use 100, but with polycystic ovarian syndrome, 200 to 600 milligrams based on labs and the body's response to it. And we adjust dose for the person. Now, if the woman is taking the progesterone, just swallowing that sublingual troche, just swallowing it whole, her labs the next morning will not show much benefit. They need to allow it to dissolve. You got to let it dissolve up here. You got to get as much absorption up here as possible. When you swallow the progesterone, you're not going to get the same amounts to be absorbed through intestinal absorption. Sublingual is going to be your best. Still, if your physician will not prescribe a sublingual troche, we could still use the pill version. Now, the pill version, there's a couple of variants we can look at here, 2 variants really. One is going to be prometrium. Now, prometrium is in an oil base, and that is a much easier absorbed product. Problem is, on GoodRx, it's like $700 for 30 pills of 200 milligrams, and it's just offensively expensive. If your insurance covers it, we should use it, because that's absorbable. Not as good as the one dissolving, but it's absorbable. Then you have the one that's kind of inexpensive, and it's micronized progesterone, the powdered inside of a capsule. Over the course of my career, I've seen enough women who've taken that have a good response, where I would say it's not a fail if you're taking it. If that's all you got, it's not always bad. We just may need to ramp up that dose more till we see the lab value supporting it. And then we would talk to the women about when they take the oral progesterone, doing it with food. Important to take it with food. Doing it divided doses, maybe in the morning and the night. Side effect, of course, we worry about is when you take progesterone in the morning, it may cause you to be a little tired. So it may cause some drowsiness. So we figure that out. So the delivery mechanism of progesterone, as always, is key. Some of you want to do transvaginal, and there's also transrectal that's out there that I've heard people talk about. I do this based on labs and results. And if this is all you can have access to and you have symptom relief, but the labs don't move very well, how are we gonna fault that? Still, I want the best for you. I want the best for you. And that means looking at the labs and making sure I move things in the right direction. That's all that matters. I mean, I can talk a good game all I want. I can sit here and sound fancy all I want by showing you biochemistry pathways, which I'm going to in a minute. I could do that over and over again, but that means nothing in the face of results for you. There's all these celebrity influencer doctor people out there talking stuff, and it sounds good, and it's easy to get caught up in it because it sounds good. But sounding good and being good are different. I remember when I first started practicing, I first got into this. I remember going to conferences and sitting through these lectures, and I was all starry-eyed, like, I'm going to do this now. I'm going to do that. This is amazing. I'm going to do this and this. And a lot of times I go home to try and practice these protocols I had learned, and they were like opposite of effective because it was a business model for the person to go to this conference, and it was a way to make money for them as a business. Just like, influencers online are, it's a business, they have a vested interest in making it look good. It's just when it comes to your health, it's so important that we get results, So anything I say that sounds fancy, that's great. It's only good until I can prove it. And that's where your labs are in. That's why I stand by this always. So we talk about progesterone. We talk about why progesterone helps. We talk about how it would help, delivery mechanisms. We talk about how to monitor it and the role it plays. Let's go to the most important thing I think that affects women, that's going to be the testosterone. Androgens are an important part of this because as a woman, you need testosterone. I need estrogen. My estrogen's out of balance. I don't feel right. I'm not healthy. You have too much testosterone. You don't feel right. You don't feel healthy. What's more so is that it's your identity as a woman. And there's a lot of insecurity that would come up rightfully when you're growing hair, when you're growing facial hair, when you're breaking out, you have acne. These are real things. And, there's clitoromegaly. There is it is a difficult thing to traverse as a human being. Women with PCOS deserve grace. and deserve care, because it is a profoundly frustrating and challenging thing for them to go through. So the thing we need to now talk about that's very important is getting that androgen level down. How do we do it? Well, in a way, I've already talked about it, but let me go more into it. When you want to get that luteinizing hormone down, that's going to stop stimulating the theca cells. That's going to cause you to make more of those androgens. So we're good on that area there. But the labs need to prove for that. How else can we be helpful for these women? Well, we need to make sure that we go after stress as much as we go after luteinizing hormone. And why stress, Brendan? Why? There's a graphic I'm going to put up here. And this graphic means a lot to me. It's common. You see it everywhere. I mean, in medicine, you see it everywhere. But I want you to look at the top of it. And the top of it, in your top left corner, you're going to see cholesterol. Cholesterol. That's all your hormones start as cholesterol, pretty much. Cholesterol. That's what it's all about. And cholesterol moves into the adrenals in this case, and then gets turned to pregnenolone. And if you see as it moves over to the right, I'm doing this opposite from you, so I'm trying to know. I know this is your right. This is my left. This is me. I'm not polished. I'm not polished at all. You move it to pregnenolone turns to progesterone. Why are those two up there at the top, Brendan? Why are those two up there? Because if you look down at the bottom, you see over this corner over here at the bottom, you see your reproductive hormones. That's where your estrogen is, your testosterone is. Why, Brendan? Why is progesterone up here, and why are the other sex hormones down here? Birth control. This is how nature has protected us from having children when we're under high stress. Because what happens is when you're under stress, your cholesterol, it moves into the adrenals to make, all the precursors to your hormones. But the brain wants to push it over here to make cortisol. So your brain's pushing that cholesterol to make cortisol because you're stressed. It's going to take that progesterone and it's going to push the progesterone into cortisol. It's going to make everything push there. And that's why women who are under high stress don't ovulate, because progesterone is being robbed, so to speak. It's a common term that's used all over the place now. Progesterone stealing, progesterone robbing. But basically, progesterone is being allocated to stress instead to make cortisol. And so that's why it's difficult to conceive or stress. It's a survival mechanism. Good one. Terrible for now. Because if you think about it, we're pulling progesterone during times of stress, and progesterone is an anti-anxiety agent that promotes sleep and promotes serotonin. For the love of Pete, you need progesterone when you're stressed for your brain. I know you don't want to have a baby when you're stressed, but man, you need those neurotransmitters. So why does that play a role in androgens, Brendan? Funky thing. It really is funky. As you're pushing this pathway really hard and you're pushing this over here to make cortisol, you see this layer underneath it that we're bypassing, that you'll see the androstenedione, you see androstenediol down there as well, and you see DHEA or dihydroepiandrosterone. They're right there. So as you're pushing along, there's going to start being this feedback. You're going to see this leak, so to speak. You're going to see some of it dropping down. You see some over-recruitment, overproduction of DHEA and androstenedione. Those are called adrenal androgens. That's why when women are under high stress, you see androgenic side effects. It's called adrenal androgens being elevated. When you have PCOS, we need to worry about your testosterone free and total. Yes. Targeting the sex hormone binding globulin, getting insulin better, getting progesterone on board. Yes. What about how stress plays a role in that with DHEA and androstenedione? So we run the labs and we verify where they are, and we have to target stress in these women. Targeting stress for them is getting success, I believe, in the work that I do, and giving them that positive sense of we're going in a direction, it's helping. That does play a role. What else? I advocate for lifestyle changes, and I advocate for using wearables that monitor your heart rate variability. I advocate for, things that will bring you to a more peaceful space. That's going to be for some people prayer, some people it's going to be exercise, some people are unique. But you really want to do everything you can in the rest of your life to do your best to just work at your stress levels. And that's something that we do specific to stress, and that's a whole nother episode. A couple of small, quick things I'm going to add in here to help lower androgens or play a role in that. One of the ways you're going to see an improvement with the androgens with these women is that you're going to be lowering insulin. So you're going to have the sex hormone binding globulin come up, and that sex hormone binding globulin is going to sequester some of the testosterone, making it safer. Other things you can do, nettles. It's an herb. It works. I like Gaia. It's one of my favorite herb companies. I'm not sponsored by them, but they're great. Another thing we'd recommend for these people would be thyroid. A lot of women who are subclinical hypothyroidism are going to have low sexual hormone binding globulin. By normalizing their thyroid, you're going to help improve that. So playing a role in this is that thyroid, and if it's being ignored or forgotten about, it may still contribute to the problem. So you always want to make sure you're getting that thyroid, specifically the T3, up above 3.5, closer to 4. And that'll help sex hormone binding globulin. One last thing, and this is something I use a lot in practice, and that's saw palmetto. Again, I always talk about Gaia as my favorite herb company, but this is one that I use, a company called Mountain Peaks, and I use their prostate formula. And that's specifically targets 5-alpha reductase. What that does is tries to slow down the production of testosterone in the body. We do 3 capsules a day clinically. Again, not sponsored and not using them, but you want to find the level of saw palmetto you need that moves the labs in the right direction. That's been the product I've had the best success with. I hope this helps. This is so important to get this right. This is an important part of your lives. Please comment, please subscribe, please share, please like. And I'll see you at the next episode.